kind invitation to talk about this topic, which is somewhat different from what we talk about usually. But it certainly deserves a lot of attention, I think. Firstly, these are my disclosures. And secondly, we've been training thoracic surgeons for many years in Copenhagen for VATS lobectomy programs. And I think this video summarizes the fears of most surgeons when they embark on a minimal invasive procedure. Safety of our patients is of utmost concerns to us as surgeons. We published an analysis at this meeting a couple of years ago, a group of institutions forming the minimal invasive interest group. And we looked at major intraoperative complications when performing VATS anatomical lung resections. And we identified some horrible cases, some really, really terrible complications with great implications for patients, and analyzed how could this happen, how can we prevent this in the future. And I think this needs a lot of focus. So in the beginning of the VATS era, we had a lot of focus on technical skills, how to learn the procedure, was it necessary to have an open experience, recommendations for how to pursue your VATS lobectomy program. But we didn't really focus on the non-technical skills. So when we have teams coming to Copenhagen, we recommend that they come as a team, not only the surgeon, but bring your nurses and your anesthesiologists, because when you want to start up a program, you need the entire team. We've had surgeons who only visited surgeons contacting us when they started their program, and they were very into all the technical bits, but the very basic parts like how is the patient positioned, where is the bend to open up the intercostal spaces, they didn't see that because their focus was on the technical part. So if you bring a nurse, she will focus on the parts that's her part in the team. So it's very important to be aware of medical error. This is an analysis showing that it's the third leading cause of death in the US is a medical error. 10 to 15% of patients worldwide probably experience a medical error during their course. We all know this Swiss cheese model. So everyone in the team needs to perform. If everyone fails at the same time, terrible mistakes can happen, like the mistakes we've seen previous in this presentation. Then again, I think it's very important to remember that to err is human. Errare humanum est in Latin. We all do mistakes, and this is very important to always remember when you work in team. This is a definition of a team, a group of 2 or more individuals who must interact cooperatively and adaptively in the pursuit of shared value objectives. Further, team members have clearly defined differentiated roles and responsibilities, hold task-relevant knowledge, and are interdependent. That's important. So when we look in a practical way, how is our VATS team? So we have there's 3 teams within a team. We have the surgical team, which is usually a thoracic surgeon and his assisting surgeon. There is an anesthesia team with an anesthesiologist and an anesthesiologist nurse. This is different from country to country, I'm aware. And then we have usually a nurse team, a scrub nurse and a floor nurse, and in some countries maybe more floor nurses. So during surgery, what are the teams concerned about? They're concerned about different things. So the surgical team are usually very occupied with the technical part of the surgery to perform, to avoid making mistakes, and to avoid complications. And as oncological surgeons, we're very concerned to be radical with our oncology, to do a full lymph node dissection, to have good resection margins, and be lung sparing at the same time. So these are our concerns, and we want to finish in due time. We don't want to have very long operations, so we are focused on time as well. So we need to progress all the time during surgery. The anesthesia team, on the other hand, their concern is mainly on intubation for the beginning, providing sufficient lung ventilation, one lung ventilation to prepare the best field for the surgeon, to have sufficient muscle relaxation so that the diaphragm is relaxed and there's plenty of space for the VATS surgeon to operate on, and then maintaining cardiovascular function and oxygenation during surgery and making sure there's sufficient renal function. The nurse team, on the other hand, they're occupied with providing the instruments for the surgical team, sometimes advanced instrument. They may be occupied with technical challenges with the tower, with the camera, if something's not working. And then they have to be prepared for emergencies. So if you need to convert, if you have a bleeding, that's on their concern. So we had a young anesthesiologist doing a PhD in non-technical skills. So we're actually moving into the area of psychology. This is not an easy area to address in a scientific way, but we tried this with our research team. And so as many PhD studies began with a systematic review, what is actually in the literature written about non-technical skills in thoracic surgery, and there were practically nothing in the literature. There were some from general surgery. This is one of the papers from that review I would like to highlight. So we've been discussing for many years in thoracic surgery, how about fixed teams? Does it really affect outcome? We all have, I think, the feeling that we like to work with the same people, and especially, I think when you start a VATS lobectomy program, the more fixed your team is, the better. The communication is much easier. Everyone knows one another, and there's a lot of onset things that just works. So this was in bariatric surgery, this study, and they could see that working with fixed team, there was a 10% reduced procedure duration, and it did not affect outcome. There were no adverse outcome. This is the very famous Oxford non-technical skills assessment tool, and we use this for our research, and it's a scoring from 1 to 4. 4 is excellent, and there are 4 topics. Leadership and management is one of the topics identified for a successful team. Teamwork and cooperation, problem solving and decision making, and situation awareness. A shared mental model is a knowledge structure held by members of a team that enable them to form accurate explanations and expectations for the task, and in turn to coordinate their actions and adapt their behavior to demands of the task and the other team members. I'll come back to this. So the second study in this PhD was an interview study where we interviewed 21 participants from all over Denmark. There are 4 centers for cardiothoracic surgery in Denmark, and this PhD student, which was actually an anesthesiologist, went to all the centers to interview the teams, and the data analysis was deductive, and directed content analysis was used to code the text within the Oxford non-technical skills system for evaluating operating teams' non-technical skills. So these are the topics that was identified by the teams, so as the most important. So it's planning and preparation, situation awareness, problem solving, leadership, risk assessment, and teamwork, and they all together form a shared mental model of the team. So these are some of the things from the interview that were highlighted. So for instance, for planning and preparation, we do a timeout at the start of surgery. So everyone of the entire team is there for the timeout. The surgeon explains, is this a routine VATS lobectomy, or this actually a central tumor where we expect a higher risk of intraoperative bleeding. So I would like the anesthesia team to be prepared, having blood in theater. I would like the nurse team to have the thoracotomy tray ready, and all these kinds of things. They're very important for safety. This is another example from the interview. Situation awareness is very important. So one of the nurses mentioned that when the surgeon she works with, she can listen to his tone. So she knows on his tone whether now this is getting serious. So if you're relaxed, if you're joking, it's usually because surgery is easy and everything is working very well. But when you suddenly become like very harsh, maybe it's because the surgeon has a problem. She knows she needs to be more aware. There are times in surgeries where you can be relaxed, and there are times where you need to be really focused. And this is very important. So in conclusion of this study, 6 specific non-technical skills were perceived by these VATS teams, and they found them of highly importance to the performance of VATS lobectomy. And they served as antecedents for the overarching theme of a shared mental model. And the shared mental model of the patient, the current situation, and the team's resources would enable these teams to anticipate problems, and hence this is very crucial to patient safety. So the last study in this PhD, we looked at the shared mental model, and we interviewed 64 VATS lobectomies pre-operatively and post-operatively by questionnaires. All in all, this was 172 different team members that were interviewed. Again, this was a nationwide study. So you went to all the centers in Denmark and interviewed the teams. And these participants' responses were compared within the teams to explore the shared mental model of risk assessment, familiarity, technical skills, non-technical skills, and problems. So this is the team members, familiarity, technical skills, and non-technical skills assessment. So in one row you see the team members' self-assessment, and in the other row you see the other team members' assessment of the particular person. As you can see on this scoring chart, so the surgeon was the one who knew the team members the best, and actually the team members agreed that he knew his team very well. They were good agreement. The technical skills of the surgeon, it's not a surprise the surgeon found himself very technical skilled, and actually the team members agreed with that. But when it comes to the non-technical skills, there was a significant difference between the self-assessment of the surgeon and the assessment of the team. So apparently this is something we have to work with. Interestingly, this is the assistant surgeon. He rated his technical skills or her technical skills lower, but the team members maybe underestimated his skills. And this is the anesthesiologist. It's very similar to the surgeon that he or she rated himself far better than the remaining team members. So this is a figure who shows on the 7 points Richter scale the relationship between the teams in surgery, and the darker and thicker the arrows are, they represent a higher percentage of agreement. And you can see actually the surgeon is probably the one who knows his team and interact best in the team, but you can see the assistant surgeon, anesthesiologist, there's a very poor correlation. So these are the challenges and problems identified by the team members. So you can see that the surgeon he's concerned about dissection, adhesions, hemodynamic. These are the problems that he has occurred during surgery. And the assistant surgeon is concerned with providing good cameras and of course also on the hemodynamics. But if you look at the scrub nurse, actually she's more concerned about her own experience and how she is performing compared to the entire team. It's very interesting. I'm gonna finish up. I have 1 minute more. Yeah, I'll be in time. So this is This is showing the relationship. So when you have a problem as a surgeon, who's the most aware? Actually, the anesthesiologist. He's the one who's most aware of the surgeon's problem. And the second one is the assistant surgeon. So thank you very much for your attention, and remember, teamwork is very important if we want to avoid adverse event and if we want to make the best performance we can. Thank you very much.